really like me. Okay, good. So, thank you very much for inviting me to lecture. This is the second time I've been asked to come, and thank you very much. I know that you guys have block schedule every 2 years, right? Yeah, so last time I lectured was 2 years ago, so it's good. Okay, so my name is Susan Law. I'm the Director of Stroke at the county, Kings County. But I'm here at Downstate, but we're going to talk about county and we're going to talk about stroke, and this is the TPA lecture. So I'm not going to, first things first is that I will say this, that I'm not going to try to convince you that you should give TPA on all your patients, okay? We're not going to do that here, okay? That is not my job here. My job here is to tell you what changes that we've been having at the county. My job is to tell you what we're doing to improve our quality of care at the county. And you also, I'm pretty sure you are probably interested in knowing our TPA hemorrhage rate, so I will put that in as well. I will tell you about our protocol and what we can do to improve and what we're in the process of improving. So, so you're wondering what we are right now. So we are American Heart as well as Joint Commission Certified Stroke Center, and we're very proud of that. It took us a very long time to do that. I remember coming in as a job 4 years ago. I went up to Dr. Jamaladdin, who was the CMO back then, and I said, I want to make this into a primary stroke center by Joint Commission. And he said, it's too expensive. But you know, after 4 years, we actually got it, so I'm very happy. And it was a concerted effort with the ED, nursing, as well as nursing education and neurology, and all the other staff members. Okay, so what does that really mean? So stroke is going through a very, very drastic change in the past couple of years. And it's probably because of the recent interventional trial, as well as the recent ischemic stroke trial. But can you see my mouse? Yes. Okay, over here, we're at the primary stroke center level. And what does that mean? That means that we're not at the highest certification, but we are in the middle, which is not that bad, but you want to be better. This was published 2 years ago by the American Heart. They actually said that we should start thinking about bypassing stroke centers who can't offer certain treatment availability for really, really bad strokes. So this was their proposed EMS triage protocol. There is an unpublished one by EMS that is circulating last year. But they're in the process of planning to bypass any hospital that doesn't offer interventional services on the select patients that they view as large vessel occlusion. So, but I'm not here to talk about that either. I'm here to talk about TPA. I just want to let you know that's exactly what the landscape is. If you guys are very curious, I could talk for hours about what EMS is doing and what our plans are, but I'm here to talk about TPA, and I'm here to talk about some papers that are very important to read. And just remember that this lecture is not a substitute for reading. You should always take the time to read on certain papers, because you will eventually come across a neurologist who would want to have a meaningful discussion with you on TPA. So the first paper, and I made a little table, but the first paper is the 1995 NINDS trial. So I always like my lectures to be little interactive. So I'm going to, I know that this row was a little sleepy, so I'm going to pick this. Yes. Do you remember what the 1995 NINDS trial was about? It's okay if you don't know, because, no, you want to know why it's not okay? You want to know why it's okay? Because it's an education opportunity. So if you don't know, you can phone a friend. Ooh. Can you hear me?
It's okay if you don't know.
I'm not sure.
Okay, you can phone our friend.
Okay, Chris, are you PGY2?
One.
PGY1, very confident. Tell me, 1995, NINDS trial.
Isn't it the one that showed that you needed to give TPA within 4.5 hours of the last go of normal?
No, it's broken. Hello?
Hello? Ah, okay. Very close. You get half point. It talks about TPA. That's half point. The 1995 trial was first of its kind. It talked about giving TPA within 3 hours, and it was divided into 2 parts. The first part talked about improvement within 24 hours by a nice stroke scale. And the second part was improvement of overall quality of life by modified ranking score by 90 days. Does anyone remember the first part? It was good result, bad result, or net? Does anyone remember?
It was net.
It was net. Very good. There was no significant improvement within 24 hours. But does anyone remember part 2? Okay, the answer choice is good, bad, or net. It was good, yeah. So they found out that after 3 months that TPA was benefit. I'm not gonna lie, that was exactly what the 1995 clinical trial talked about. And it was considered very monumental because it's actually proven to have some sort of treatment for acute ischemic stroke. Now, we can talk about TPA and we can talk about what exactly happened, but this actually marked the beginning of stroke centers and stroke units, because it actually talked about there was meaningful treatment for these patients. Okay, does anyone remember 2005?
Is this when they modified the time frame to say it's more effective in the less than 3 hour window? Or like door to TPA time an hour, something like that? They adjusted the time frame.
Okay, you get half point. It talked about modifying something. Very good. So it actually talked about whether or not, this was actually a paper that explored whether or not TPA was beneficial for minor stroke symptoms. And it was an argument from the emergency medicine as well as neurology department to talk about, because neurologists wanted to give it to all strokes, whereas emergency medicine felt that it may be too much to give it. So it was a discussion paper on whether or not it was meaningful to give TPA to minor strokes. Okay, how about the 2008 one? This is an error. It's supposed to be 4.5, but I was rushing. Okay, I'm going to go point to the sleepy road again.
It's where they modify the time.
Oh, excellent! Good job! Very good! Excellent! They talked about the modified time window. Do you remember the contraindications of that modified time window? Okay, that's half right. So during 3 to 4.5 hour window, it's 4 contraindications additional to the other contraindications. One was 1/3 of the one-third of the cerebral hemisphere is infarcted. Second is history of stroke and diabetes. Third is history of anticoagulation. Does anyone remember the fourth one?
Recent large bleeding?
Well, that's an absolute contraindication for everything. So does anyone remember the fourth one? The fourth one was controversial, but it's a very advanced NIH stroke scale of more than 25. So, okay, let's just skip a couple of things. Now, I do want to say that when you do read these papers, and I'm going to give it to Matthew, it's good that these are the basic papers that should be talked about and read. I always like my residents to read these papers as well. And I don't know how many of you guys rotated when I was on service with you. I know Matthew has. Yeah, I make you guys suffer. I make you guys read some papers and be NIH stroke certified. So, but it's always good to keep an open mind, and that there's a lot of things that we don't know. But the most important thing is that, is there a greater than 3-hour benefit by the 1995 clinical trial, and that what type of strokes are most beneficial? But we don't know. All we know is that these patients, when you give TPA very quickly for the right patient, they are beneficial. Does anyone know what the PRISMS paper was? It just got published, the PRISMS paper. It got published it was actually, downstate was a clinical flight. Anyone know? This is a PGY 3+ question. So I'm going to point to it as PGY 3. What do you think?
I haven't read the paper. I know that it's been circulating, but it's basically, it shows that there's not a, take-home point is there's not a large difference between TPA and aspirin.
Oh, very good. So I circled and highlighted a link directly from the JAMA website. It says visual abstract. It's like perfect for Instagram. We actually posted the visual abstract. And they found out that there is no, it was a net trial. Net trial means no benefit. The aspirin or aspirin versus alteplase for minor stroke symptoms of NIH stroke scale of 5 or less. Now this is a trick question. Can you have a disabling stroke with an NIH stroke scale of 5? Are you sure? What if you have aphasia of 3? If you have aphasia of 3, you automatically have dysarthria of 2 in case you're in your NIH stroke scale. So 3 plus 2 is 5. If you're aphasic, it's pretty disabling, right? So the editorial of this paper actually talked about that, this PRISM trial talked about that even though TPA may not be as great for non-disabling strokes, still NIH stroke scale of 5 can be considered very disabling. So it requires clinical judgment, and that's where you fall in, because you are in the front line. So we're here to talk about stroke. We're not here to talk about anything else. So when someone has a stroke, acute treatment, I like to divide it between 2 things, whether it's a bleed or a clot. Because if it's a clot, I gotta find out if the patient is going to get TPA or not. And this is a very trick question. Matthew, I think I need to ask you this question. How long is the golden hour? Yeah, very good. I've gotten answer choices ranging from 45 minutes to an hour and 15 minutes whenever I ask that question. A golden hour is 1 hour long. And I know. So over here, it's the moment the patient actually arrives at the hospital, the clock starts ticking. And you have to give, we are monitored by the hospital to give IV thrombolysis immediately. And usually you are at the front line, so it requires a establishment of care within 10 minutes. And then the stroke team has to come in within 15 minutes. But usually what happens is, what I noticed is that when you call a stroke code, we answer very quickly, and it's because we're very proximal to the ER, which is very, very good thing. I remember when I was in my prior hospital, I had to walk 1 block to get to the ER. We're very lucky that we're very close to the ER. And then they go to the CAT scan. Sometimes by the time the stroke team comes, they're already in the CAT scan. And we feel kind of left out, but we meet you at the CAT scan. And then during that time, we have a remainder of 35 minutes to get TPA into the system. And I'm going to show you since 2014, so it's about, we're in our 5th year. We only have 300 and something ischemic strokes a year. And out of that, we actually give only TPA pretty much less than 10% of the ischemic strokes. And what does that mean? That means that the national average for people who give TPA is actually around 4 to 5%, whereas we're about double the national average. But I actually asked a couple of the hospitals. Some hospitals go up to 15% giving TPA. We're actually right in the middle. We give a TPA around 10% of all ischemic strokes. And I remember when I first started, people's perception was that we're starting to give a lot of TPA. It's not that. It's actually we're giving TPA appropriately. It's just there's more strokes coming our way. People always ask me, what is the door-to-meal time? What's the average door-to-meal time for our hospital? So our goal is less than 60 minutes, but my personal goal is less than 45 minutes. And we actually hit that goal this year, the first time ever in our history of the hospital. Our average door-to-meal time is less than 45 minutes. And it's because of just going through the protocol and engaging nursing as well as you. What is our hemorrhage rate? Our hemorrhage rate is, does anyone know the national hemorrhage rate? It's a trick question. So when the NINDS trial came out in 1995, it was 6.4%. But then in 2012, a large registry was performed by the guidelines, and they found that it was less than that. It was around 4%. So 4% symptomatic cranial hemorrhage rate. So as you can see, in 2004, we had a lot of bleeds. And in 2005, we had none. But over here, we're at actually 3%. So we're lower than the national average. And it's because we actually did an analysis of why patients bleed from TPA. This is actually something that's really important. So the sleepy rope needs to be more based. We found out that the reason why patients bleed is not because we're giving them inappropriate, it's because of the aftermath of when they got TPA. So what happens afterwards? This is actually from 2009. So these are actually all the TPA bleeds since 2009. And upon analysis, majority of them actually had fallouts due to blood pressure requirements and not enough blood pressure regulation. So my question is, who takes care of the blood pressure after the TPA?
We are the admitting team.
The admitting team. Yes, I would love to say it's because of the ICU. Unfortunately, the ICU sometimes requires, they're a little bit slow, which is kind of weird. Majority of the time, the patient is actually in an ED, so it requires a concerted effort on your part as well as the neurology and the ICU, because it's in between. And during that time where the patient is trying to go to the ICU, the patient is still in the ED and requires blood pressure management. So we actually made the hospital adopt a plan and a policy that a TPA patient cannot stay in the ER for more than 6 hours unless there's absolutely no beds in the ICU. And I don't know how long that's going to hold up, but we'll see. So far we haven't had any bleeds in 2018. So So what do you do during a stroke? And I always get asked these random questions, like what do we do? What are we going to do with our 24-hour stroke codes, right? So the most important thing is that it starts with the nursing, actually, from triage. When the EMS people come, they're only effective 25% of the time. Did you know that? So they call notification, they're only positive 25% of the time. So majority of the time, they're missed by EMS, and they're missed by walk-in triage. So we developed a BFAST system, which included posterior circulation stroke and anterior circulation stroke. Because what happens, and everyone knows this graph, I'm pretty short, and you've probably seen this ad nauseum, but as you can see that it's a curve where the longer it takes for you to get TPA in the system on a large vessel occlusion, the effectiveness actually increases significantly. And they published this 2 years ago that if you shave 15 minutes off of a large vessel occlusion, like doing TPA, you actually give them 1 month of healthy living. So what do you do? The first thing is that you gotta look at the blood pressure. The blood pressure in our population is the worst. I've worked in other hospitals, I did locum, and the patient usually strolls in and says, oh, no, it's a pre-notification, and they call a stroke code, and then the blood pressure is 160. And usually a guy can perfectly articulate, my last Noel was 5 minutes ago, or 15 minutes ago, it's like perfect. But in our population, that's not usually the case. The blood pressure is 230, or it's very high, and it's always very difficult to manage the blood pressure. It requires IV medication. And that's actually one of the reasons why we have so much difficulty in giving TPA. The blood pressure before you give TPA has to be less than 185 or 110. So as soon as there's an agreement established to give IV thrombolysis, your aim is to make sure the blood pressure drops. And does anyone know how much labetalol you're supposed to give? I know that Dr. Kapinas talked for 1 hour about the number of salvaging, which sounds like an art exhibit in a med, but how much labetalol are you supposed to give? The answer is right here.
10 milligrams IV every 15 minutes to a maximum.
Yeah, you're not supposed to give more than 20 milligrams of labetalol based on our TPA protocol. And what I noticed that when you finally drop that blood pressure, the labetalol only stays in the system for only a couple minutes, but you have 24 hours of monitoring that blood pressure. So usually I do rule of thumb is that if you need 2 pushes, you should just start a drip. And he talked about TCDs, so I'm going to talk about TCDs for a second. So this was actually a front page this was a front page cover of Stroke Magazine, Stroke Journal, where someone actually intubated the middle cerebral artery after getting IV thrombolysis. Can anyone give me a time frame when the patient got worse? This is like I feel like this is like a Richard Sinner question. Dr. Sinner, what time frame do you think patients get worse after IV TPA?
Too soon.
Too soon. That's absolutely correct. So they usually say within 1 hour after infusion, and that means 2 hours after the bolus. And so where is the patient usually located? In the ED. And I will tell you for a fact that the nurses, they always call you guys before they call the ICU team. And it's important to know that you have to worry about intracerebral hemorrhage, and you stop the IV infusion. So what do you do when you actually have a patient who goes in a stroke? Well, yeah, hopefully you'll call a stroke code, but usually what happens when I go to a stroke code, and I'm being very honest here, it's usually in the stroke assessment area or the CCT, and usually it's quite chaotic. But I like to stand in the corner and I like to try to grab an ED resident and ask them, so what's going on? So the only thing that I'm listening for is last known well, which usually sometimes I do not get unless I ask. But that's actually the most important thing during the stroke is last known well. Because if the last known well was 16 hours ago, I know I can't give TPA. And maybe the patient might benefit from the CTA. I don't know. But the last known well, whether it was witnessed or not. Other past medical histories that are important is any medical history that requires anticoagulation, seizure, or cancer history. And the reason why is because I'm looking for reasons not to give TPA that are considered unsafe. So what is the nurse's responsibility? I always get this question. What is the responsibility of the ED physician? What's the responsibility of the nursing physician? And nurses. So the nurse is supposed to get a finger stick and vital signs in this phase. Hopefully they escort the patient to the CAT scan, but sometimes they don't. But the main issue actually is that the ED physician is allowed, we ask the ED physician to order the CAT scan. The reason why is because you have computer open. That's the only reason why. You have computer open that's logged into your name in the ED. We are more than happy to order the CAT scan on our behalf, but that means we have to log you off. And you don't want us to log you off of the computer. So we always ask to order the CAT scan. It's true. And when should we order a CTA? Does anyone know about when? Oh, that's good. That's half right. I give you half point. So usually we ask them to do a CTA if the patient actually presents with cortical signs and or a NI stroke scale of 6 or greater. And the reason why we do that is because we're looking for a large vessel occlusion. Now, I get this question a lot from ED. Why won't you do CAT scan and CTA together instead of transporting back and forth? Okay, I get that question a lot. Unfortunately, the turnaround time is more than 15 minutes on average, and we're working on it to combine them together. So we're working on combining them together, but at this point, they have to be separate. So who makes the decision to give TPA? Oh, yes, Dr. Willis.
I've had pushback from the neurology residents for not putting in IVs before they go for their initial CT non-con. So I just want to understand, your ideal protocol is for the patient to get the finger stick, the nurse assessment, the assessment, go to CAT scan and get a non-con, come back, decide if they need a CTA, then go back to CT. Because that's what I tried to enact a couple of times, but then we've had a delay in going for the initial CT because the neurology resident wants to like use those.
So I consider placement of IV as part of medical stabilization, and if the patient needs an IV before you consider them stabilized because they need like B50 or something else, then of course they need an IV. Right. But your protocol is actually correct. I'd rather have the patient go to CAT scan. If you deem them stable, because you remember, it's your house. The ED is your house. So if you deem the patient stable, we're more than happy to accompany them to the CAT scan, and then you can do all the lab work afterwards. So who actually makes decisions to give TPA? It's a very touchy subject. I know that the ED doctors, they're at the edge of their seat. Yeah, it's the patient. The patient makes the decision. You don't make the decision. The patient makes the decision. We always offer when we deem it's necessary, but it's ultimately the patient's decision. And you can sell it both ways, and I'm being very honest. I've had people sell TPA in front of me in a very negative light, and I've had people sell TPA like it's the best thing in the world. It's all how you want to present it. And that actually encompasses clinical decision as well. Usually when I run a stroke code and I want to give TPA, I always talk to the attending as an attending, and I tell them, look, I think the patient needs TPA, and if there's any issue, then it requires a healthy discussion. So it's usually done by the patient makes the decision, but also in conjunction with the ED and the neurologist on call. Less than 3 hours, we don't require written consent. And we're actually, there was actually a paper on who should be consented for TPA, and we're right in the middle. I don't know if you sense the pattern, we're right in the middle, where we actually, majority of the less than 3 hour window require a verbal consent, whereas beyond 3 to 4.5 hours, which is non-FDA approved, we actually require a written consent. So that's very important. What if the patient's a basic?
Family member?
Well, no family member. So it's a truly ethical question, because then you have to ask yourself whether or not the patient is eligible for TPA. Because if the patient can't provide a history and no one's around to provide a history, you don't really truly know the patient is eligible. And we actually had an issue with that, with a patient who I gave TPA, and he was a basic, and the only thing that saved his life was that he had his entire medical record at the county, and that was the only reason why I was able to give TPA. So I'm going to, how are we doing on time? Oh, okay. I'm going to go super fast now. Okay. So I leave you for Donnie Bell to talk about what to do for endovascular therapy, but I know everyone's asking me about diffuse 3 and Dawn trial. Yeah? Okay. Just to put everyone on the same page, the diffuse 3 and Dawn trial talked about endovascular therapy beyond 6 hours, and who are good candidates, which I'm sure that it's very, very difficult to figure out, especially since you're ED doctors. Neurologists are still confused about it too, and what is the proper way to evaluate these patients. But I'm going to give you an example of a patient who I didn't think he should have gotten he didn't get endovascular therapy, and I actually agreed with it. I agreed with it. So this is actually a snapshot when I died. He's 53 years old, and the stroke scale was 16. He came in with right-sided hemiparesis. He was aphasic, and his last normal was 13 hours ago. So that's the only information that I cared about. So this is a snapshot of the CAT scan. Can anyone tell me what they think? So let's make an agreement. Should this patient get TPA? No. Okay, fantastic. And the reason why this is everyone gets a gold star. The reason why is because it's beyond 4.5 hours. Okay, that's absolute contraindication. The patient should not get a TPA. But it's very sad because this patient has devastating strokes. What do you do? Okay, do you think this patient, so what do you think it is, right? What do you think, this is your answer for it. Of course you're going to say that it's a stroke, you dummy, and in fact it's probably a large vessel occlusion, or you want to say it's a large vessel occlusion. So the reason why, and most people will say, okay, in a CAT scanner, I'm not going to get TPA, I'll go straight to CTA. And that's exactly what happened with this patient. The patient went straight to CTA and found to have a large vessel occlusion. Unfortunately, this patient was not a candidate for endovascular therapy. And the reason why is, and I'm sure our next speaker will talk about it, is that if you already see ischemia here already, that means that's dead tissue. That means it's over already. No matter what happens, it's dead tissue. And it's dead tissue, meaning that there is risk of bleed if you take out the clot. And you don't want that. You will actually send them to a procedure that will do more harm than good. And so this patient was unfortunate, wasn't a candidate. So now everyone's asking about the prisons. The Fuse 3 and the Dawn trial. And all the hospitals in New York are actually having difficulty with 24-hour stroke codes. So we made the decision by the ER to make only 24-hour stroke codes isolated in the critical care trauma region first before we expanded to the hospital. And the reason why we did that was we were concerned about burnout from the resident point of view. So, so hopefully we'll start very soon with 24-hour stroke codes. I think that's about it. I wanted to keep it very short. I'm glad everyone is still awake, and thank you very much for your attention.